Okay, so I'm going to be talking about new targets and new therapies for hairy cell leukemia. And fortunately for this disease, over the last couple of years, it's been very exciting, and there are lots of new therapies and new targets to talk about. So first, what is hairy cell leukemia? Well, it's a B-cell leukemia that is comprising 2% of all leukemias. When it was first described by Bertha Bronkley in 1958, that was about 600 cases a year. People still say that, but now it's about 1,000 cases a year in the United States. There's a fried egg appearance due to abundant cytoplasm in the bone marrow. There's cytoplasmic projections, you can see by EM. The cells are positive for B-cell antigens, as well as CD103, CD11C, and if it's classic, CD25. So this is summarizing the early effective systemic therapy for hairy cell. All these articles, or the first two, come from the New England Journal on first alpha interferon, which had a reasonable response rate, but in multiple trials, a CR rate of only about 5 to 10%, and the partial responses are fairly transient when the interferon is stopped. So this is a drug mainly of historical interest, although you can get some responses. The purine analogs are really the backbone of treatment for hairy cell. First with pennistatin, also called deoxycorphamycin, published in the late 80s to give complete remission rates of between 70 and 75%, with overall response rates close to 90%. And most of these patients are still in complete remission even 8 years later. And a randomized trial organized by Dr. Griever at Ohio State really confirmed the superiority of purine analog pennistatin over interferon. Now, we don't use pennistatin anymore usually because cladribine can give the same results, but after a single 5 to 7 day infusion. The complete remission rates are similar. The disease-free survivals are also very similar. But evidence is lacking that cladribine can eradicate hairy cell. Same with pennistatin. That there's no plateau on the disease-free survival curves even after 25 years. And Siegel et al. From Dr. Savin's group at Scripps found that out of 19 patients studied a median of 16 years after being in complete remission. This is out of originally 358 patients treated for hairy cell. That MRD was present in most of these patients. And if you look at the outcome of hairy cell over several decades, this is by Elsie et al. In the UK, we can see that the curves reach a 50% line around 16 years of median observation. And so the relapse-free survival to the first line of cladribine is about 16 years, second line about 11 years, third line about 6.5 years. So the median time to having purine refractory disease is about 34 years. So if someone's going to be in the median and they're elderly when they get diagnosed, they're probably not going to die of hairy cell. But patients who are very young, and we see patients in their 20s, they're probably going to die of hairy cell at the current standard of practice. And the purine analog refractory disease is a difficult situation. And it's important to note that Dr. Golem in 1978 found that the median overall survival of hairy cell was only 4 years before effective therapy. And these patients, after getting multiple purine analogs, are also beat up from an immunologic standpoint. Now, this is hairy cell classic, but hairy cell variant is considered now a different disease by the World Health Organization, and this is about 10 to 20% of patients. The splenic enlargement is much more severe. These patients tend to have large lymph nodes, and they tend not to have cytopenias. They tend to have lymphocytosis instead. They're negative for CD25. They can be negative for CD103, although usually positive. And annexin is negative as opposed to being positive in classic hairy cell. But these patients are primarily refractory to purine analogs, even in first line. So originally, these are considered two separate diseases at this time, but a variant called VH434, where the patients express immunoglobulin rearrangement VH434, and it's unmutated, these patients have a markedly poor prognosis, whether they express classic immunophenotypic antigens or variant. So I want to bring up the monoclonal antibody-based treatments for hairy cell. First with rituximab, since it's been approved, and in the largest trial where this was tested, the complete remission rate was only 13%. And this is in a trial where patients, number one, had prior purine analog, and they needed treatment due to cytopenias. You can get better results if patients are newly diagnosed, they've not had prior purine analog, or they have only minimal disease, they don't have cytopenias yet. So although the response rates vary in the literature to rituximab alone, if you treat patients who are the kind of patients that we would treat for multiply resistant hairy cell, you get response rates that are rather low. And rituximab added to cladribine or pennistatin give much better results, although it's more toxic. Now this is a study that was done by Ravandi at MD Anderson. And this followed patients after treatment with cladribine, followed 1 month by rituximab. This is 8 weekly doses. And found a 100% complete remission rate in 31 patients. And the MRD rate before, the MRD rate was 21% out of 28 patients overall. And in hairy cell variant, 2 out of 5 patients had CRs lasting 12 and 35 months. A couple patients died of secondary malignancies. 1 patient had a relapse leading to death. So in hairy cell variant, we have actually published, and it's in press, a report of 10 patients treated with cladribine followed immediately by rituximab rather than 1 month, but really rituximab starting on the same day. And we have a 90% complete remission rate. 80% of those patients are MRD-free. By MRD-free, minimal residual disease, I mean that flow cytometry in the blood and also bone marrow aspirate are both negative. It's much harder to be negative in the bone marrow aspirate by flow than the blood. And of course, immunohistochemistry of the bone marrow biopsy is also negative. Now, bendamustine is also considered a purine analog. It's also an alkylator agent, as you can see these alkylator groups. And it's similar, the alkylator, the purine analog ring is similar to what's found in cladribine. And we reported a case report of a patient getting bendamustine alone for hairy cell. The interesting thing about this agent is that you can get a very good response in lymphadenopathy, which we've had trouble getting with biologics. And the massive adenopathy you can see when patients have splenectomy. So we performed a phase 2 trial at the NIH comparing bendamustine rituximab versus pennistatin rituximab, and that trial is ongoing. But what I want to do in this slide is present just preliminary dose-finding studies that we did with 2 dose levels of bendamustine and rituximab. And really, this is the first data using bendamustine and rituximab BR for multiply relapsed hairy cell. And we found a 100% overall response rate in either dose level 70 or 90 milligram per meter squared given days 1 and 2. The complete remission rate was similar in both groups, 50% versus 67%. Patients were MRD negative more often in the high dose group, and the median time to CR was also shorter in the higher dose group. Obviously, these are not meant to be statistically comparable, although the p-value here was 0.004. So we find that patients can be followed with soluble CD22, which for the hairy cell variant patients, and for those patients who over time lose CD25 expression, is a much better marker. And we find that when the soluble CD22 level goes below 2 nanogram per mil, it correlates with CR. You can see with flow, and you can see this becoming undetectable. In PRs, they tend to be higher than 2 nanogram per mil. The overall disease-free survival of these patients is excellent if they get CR. But as you can see, if they get PR, they do not fare very well. Their median relapse-free survival is only 19 months. So I want to talk about recombinant immunotoxins, because the advantage of these agents is that they don't work like chemotherapy, and I'll talk about exactly how they work. We found with our first one, LMB2, targeting CD25, as published in Blood, 100% response rate in hairy cell leukemia, and we have a phase 2 trial where we've seen additional CRs and PRs. But I want to focus on CD22 because as opposed to CD25, which can be lost in classic hairy cell and also is certainly negative in variant hairy cell, CD22 is always expressed in high levels. And we reported in the New England Journal in 2001 a high response rate, high complete response rate with BL22. And in JCO, the overall CR rate was 61%. This shows how this molecule works. First, we take the Pseudomonas exotoxin, which is a single-chain toxin produced by Pseudomonas aeruginosa. We take off the binding domain, and with this residual C-terminal fragment, we connect that to the variable domains of the RFB4 antibody targeting CD22. And so the variable domains bind to CD22 on the cell surface. They internalize through a clathrin-coated pit, and at acidic pH, there's an unfolding event with a proteolytic cleavage that occurs in domain 2, in the yellow domain here, and that allows this C-terminal fragment, after reduction of the disulfide bond, to get it to shuttle by the KDL intracellular sorting receptor from the transreticular Golgi to the endoplasmic reticulum. And then once there, it can find pre-existing pores to translocate into the cytosol. Now, once in the cytosol, one molecule is sufficient to kill a cell because it works enzymatically to ADP ribosylate elongation factor 2, and the cell dies by apoptotic cell death. Now, we found that the activity of this molecule in hairy cell was excellent, but not in CLL. And so to improve the activity in CLL, its affinity was improved. So we found that the off rate was rather high. And by converting amino acids 100A, B, and C, we did this by phage display in collaboration with Ira Paston's lab to THW. We had a 14-fold improvement in affinity due to lower off rate. And so we originally called this molecule HA22, and it was renamed CAT8015, and that's what the trial is named. And then finally, moxetumomab pseudotox, and we call it MOXIE for short. And you can see that cytotoxicity, as measured by IC50, the concentration necessary for 50% inhibition, is 8.3-fold improved in CLL and about 2.4-fold improved in hairy cell. And so moxetumomab pseudotox in this published report in JCO showed a complete remission rate of 46% in patients with multiply relapsed hairy cell, and our overall response rate was 86%. We found complete remissions as low as 10 microgram per kilogram times 3. Obviously, we could not look for a dose response, but at 50 microgram per kilogram, this plus an additional 21 patients that were treated, we now have a complete remission rate at the MTD of about 63%. So I want to talk about BRAF because a lot of people are excited about this target. So the Italians in 2011 reported that after total exome sequencing in one hairy cell patient, they found BRAF V600E, the same mutation that was seen in 50% of melanomas, 7% of colon cancers, and other cancers as well. It was not seen in other hematologic tumors. HCLV wasn't originally characterized, but multiple studies confirmed this 100% expression of BRAF V600E in hairy cell. We found at the NIH, in focusing on multiply relapsed patients, that all of the patients we had with hairy cell variant were wild type. In other words, they did not have this mutation. And in fact, patients expressing VH434, the poor prognosis variant that can express classic antigen. So it looks like classic hairy cell immunophenotypically. In our hands, this is always negative for the BRAF mutation. So we find that hairy cell leukemia is a heterogeneous disease with some variants defined only molecularly, and BRAF can be wild type even in classic hairy cell. And by doing total exome sequencing of hairy cell variant patients and VH434 patients, we have found, in collaboration with Paul Meltzer's lab at the NIH, that MEK mutations, which have never been described in hematologic malignancies, are found in a high percentage of patients with these abnormal variants of hairy cell. And this is in press in Nature Genetics. So there has been a rapid development of agents targeting this MAP kinase BRAF pathway. Starting with the approval of murafina based on the study comparing it to dacarbazine DTIC for the BRAF mutant melanoma, leading to improved survival and PFS. So in a patient with hairy cell, this is published in the New England Journal by Dietrich et al., that a patient with multiple relapses, severe cytopenias, was treated with vemurafenib during this time period right here, and you can see a near complete disappearance of hairy cell MRD, but not complete disappearance. And although this patient was negative for soluble CD25 and hairy cell minimal residual disease at the 6-month time point, at least in the blood, this was not a cure for this patient. And when you have multiply relapsed patients, they tend to relapse very quickly. So this is another transient response that was reported in the British Journal of Hematology. And you can see that day 37, almost all the cells are gone, but by day 6, they're back to almost pre-treatment levels, this population of hairy cells. And there are other anecdotal responses of hairy cell to vemurafenib, and there are several trials going on, one of them based at Memorial Sloan Kettering. For example, a patient who's had a 27-year history of hairy cell began vemurafenib at 960 milligrams, Q12 hours times 3 weeks, had to stop due to arthralgias. This short course led to a decrease in the bone marrow of 68% to less than 5% by morphology and 10 to 20% by IHC. This report here showed a complete remission, although MRD was not reported. So vemurafenib can induce responses, including CR and hairy cell, but durability and eradication of MRD has not been reported, and relapse occurs. So this is another strategy targeting both dabrafenib and targeting both the BRAF and the downstream MEK pathway, with dabrafenib targeting BRAF and trametinib targeting MEK. And this is a in vivo study in mice showing synergistic activity with the combination. But besides being more effective, combined treatment is also less toxic than single-agent BRAF or MEK inhibition. You can see that in the mice who get the BRAF inhibitor alone, they get this thickening hyperkeratosis that is seen in patients. Also, patients get squamous cell carcinomas. But with the combination, you don't see this, at least in the mice, and in patients it's much rarer. And this is a model of why this might be the case, because BRAF inhibition will not only block the pathway that's mutated, it enhances the normal BRAF wild-type pathway. And so this can lead to side effects. Inhibiting MEK alone also leads to side effects. But when you use BRAF and MEK inhibition, this enhanced stimulation going through the native wild-type pathway is inhibited, and so you see less toxicity. Now, more work has to be done from a clinical standpoint to get significant data in this regard. But trials are opening of hairy cell using this strategy. So in conclusion, purine analogs, cladribine and pennistatin, are highly effective in first and second line for hairy cell, and are usually non-curative, and MRD is very common. Patients with hairy cell variant or VH434 classic hairy cell are primarily resistant. Rituximab has limited activity in hairy cell as a single agent, but high activity combined with purine analogs. Bendamustine, or BR, is active in relapse refractory hairy cell. LMB2 targeting CD25 is active for CD25 positive relapsed or refractory hairy cell. But moxetumomab pasudotox targeting CD22 achieves complete remissions in a high percentage of patients. And this in most of the complete remissions are now without DLT, at least at the maximum tolerated dose. BRAF is an important target in most, but not all, of hairy cell. Vemurafenib is a useful agent in V600E positive hairy cell, but MRD negative CR is not reported yet, at least in my knowledge. New targets in hairy cell and hairy cell variant are being sought for therapy. So in summary, the only agents that I know of that can give MRD-free complete remissions in a high percentage of patients is a combination of purine analog and rituximab and moxetumomab pasudotox. Thank you.